So again, yeah, my name is Mike Miga. I'm from Vanderbilt University. I'm the director of the Vanderbilt Institute for Surgery and Engineering. Some of my disclosures are shown here. I'm supported by the NIH, and I hope to get to my project, co-PI project with the for the Wellcome Trust as well. So it's great pleasure to be here. All right, let me see if I can get this going here. So hopefully, as far as as far as provocative questions go, is what is the audience going to get out of this to some degree? Hopefully we'll get some novel research directions potentially, hopefully some new methodologies. Perhaps I may inspire something from the domain, and if nothing else, I'll be a little bit entertaining and a little bit of a different perspective on these things. As far as what I know and what I can kind of contribute, I consider myself kind of a clinical device system scientist to some degree. And so our group was one of the first groups to ever produce the first FDA cleared image-guided liver surgery system that you see right here. It's just kind of a little bit of an offshoot from kind of standard tracking systems. But you see it kind of in use over here. It involved kind of a surgical planner that allows you to kind of plan these nice aspects of intervention in the liver. We could do residual liver volumes and whatnot and plan actual surgical planes. And then we could bring that information into the operating room and allow it to guide the surgeon. So it's a pretty useful device. As far as outcomes. See that was translated. It was actually probably used on about 1,000 patients or so. It was bought by Analogic, and it would at the time BK Ultrasound was part of Analogic, and they were looking at kind of developing an ultrasound-based kind of approach with the system, kind of a modified one. That moved on. Unfortunately, there was restructuring going on. It didn't actually get there, but this is the cassination system, which actually came in under our FDA clearance, and so they actually brought their system to the U.S. market. It's still being used, but it's been retasked also into the interventional radiology domain. It's being used in a lot of ablation type work now. It's interesting. I think we were a little bit before our time in terms of image-guided liver surgery. It took a little time for the kind of the robotics aspects and things like that to catch up and some of the instrumentation, but I think it's starting to come around again. I think if we have formed our company now, probably in better shape at this point. So as far as, what are the counterfactuals to investing in time and listening to me? I work in a pretty difficult environment. You've probably seen that already in some of the talks. But the procedural environment, actually taking data and actually working in that environment, it's one thing to build something on a bench. It's a whole other thing to put it in the operating room. And so you can see a lot of the work that we've done in the past, putting in, tracked objects into open resections for liver resection, trying to take novel devices and get it into the OR in some kind of sterile manner kind of down here. And then you can see kind of some of our guidance work that we've done in the past for doing experiments. This is actually our guidance system. We took our software and put it on the Cassination's hull and kind of used that within the operating room to kind of do some testing. We're still doing some testing on that. And then we also have here in the neurosurgical system, a different system that we were working on. And you can see actually there's two displays. There's one here and there's one here. We actually had to put our guidance system next to the other system and kind of get it all in there to actually do some testing. So it's a pretty challenging environment in general. That's kind of one of the counterfactuals for kind of going after this type of research. So what am I trying to achieve today? Hopefully provide you a new perspective on guidance you may not have considered, and then hopefully maybe inspire a little bit as well. So it's good to take a look at where guidance has been, and it's still here effectively. So standard of care neurosurgical systems still use these three principles, which is imaging data, which reflects kind of the anatomical aspects of the patient. We use that in the context of displays within guidance systems. Then we have that provides us our image space, and then we have localization, which is our physical space, trying to locate the patient within the operating room to allow it to digitize and kind of understand where that patient is. And then we have this idea of alignment of those two spaces, image space and physical space, and trying to relate one to the other. And that's the process of classically rigid registration. And so that's what, typically when you think about a roadmap being provided from imaging data to allow you to move through tissue and be able to look at that roadmap as you do so, that's the classic kind of representation of conventional guidance. But over the last really decade, to some degree, we've seen a pretty dramatic change. And really it's been about kind of what information can we bring, what are the sensor aspects, what are the visualization aspects, and how sophisticated have we got in terms of mathematics. So the imaging data now can be complemented with things like physical parametric data or pathology data or even predictions, okay? And as far as the localization, while we had standard optical tracking systems, they're still used, we still use them, but there's also really more advanced aspects of computer vision, more actually and come down in cost quite a bit, as well as robotic systems. I look at a robotic system as purely a way of doing localization, more or less, and actuation. We also have non-rigid registration turning into non-rigid registration and deformable models and artificial intelligence, aspects of that in terms of computation that are influencing that. And I think also visualization, where visualization was kind of put away for a while, now it's coming all back with respect to augmented reality, mixed reality, holography, and different types of sensing methodologies. You really are seeing a maturing in a different way that we've seen in the past. This is an example of one system. It's a little bit of a prototype. It's kind of an eye in the sky type system we were working on. It's for breast, which I'm probably do a lot of context of breast surgery here. And this is work that was done by my graduate students, Morgan Ringel, which Winona Ritchie, with a lot of other folks assisting, as well as our surgeon, Dr. Ingrid Mazoy. And what you're seeing here is essentially essentially a computer vision payload, more or less. It's doing optical tracking as well as with classic tool tracking. But then we also have stereo camera aspects, doing tissue tracking. We have a guidance display and a typical ultrasound. All these things being integrated for the patient. We've used it in the OR, kind of seeing here again this eye in the sky kind of aspect of kind of observing and measuring is kind of how we looked at it. And you get a sense we moved on to more sophisticated stereo pairs. This is actually the Stereo Lab system. It's used for robotic vision, but you can see here pretty a pretty rich detailed point clouds being generated. So up in the top screen here you have standard lumpectomy being performed. You can see lots of things being tracked in textured point clouds down here, all at video frame rates. And so the sensing capabilities is quite remarkable. And then you think about some of the sophisticated aspects in AI and computer vision that we've done. You could do things like track how the breast is actually deforming in this case, and you can see kind of these markers. In this case, we've turns out with breast surgery they often mark up the surface of the breast, so putting on letters is not a big deal. And so the idea of using these as ways of tracking kind of how the tissue is deforming, tracking tools, as well as kind of seeing even how the imaging devices, in this case ultrasound, were interacting with the breast is pretty remarkable. And we can do all that kind of in very fast time for, again, trying to bring more information to the surgeon during the case. So what might an advanced system might look like? You could look at it from this perspective. This is kind of how we look at it. So you can think of, yes, we're still going to have anatomic data. You can't replace anatomic data, but we might have other parametric forms, things like elasticity imaging. When I'm talking about kind of predictions and models and soft tissue and deformation, elasticity might be an important factor. And from there, we're kind of building kind of automated ways of creating kind of computational models from that. And from that, we can actually build real soft tissue, complete biomechanics associated with that. And then we can have kind of sensor systems, intraoperative sensing, things like robotic systems, maybe perhaps surveilling tissue, as I've shown before, perhaps having a HoloLens associated with display on the surgeon as well. And then from that, we can have sophisticated AI methods, to actually quantify, capture that data, and actually process that data we mentioned before, and really give us measurements, not only tool positions, but soft tissue, kind of how they're interacting. That's kind of where we're going. And then the idea is to collect that data in such a way that now it allows us to bring the imaging from the preoperative state into the intraoperative state and reflect true tissue presentation at the time of surgery. And so one of the challenging things with this is what's the nature of that data? And it's actually pretty tricky. You have things like fiducial data, perhaps some skin surface, perhaps some ultrasound, but ultimately it's very sparse data. So how do you use that to kind of correct the roadmaps when all that data was taken preoperatively? And that's something we work on. So the next slide you're going to see is I have a green set of images, which is the ground truth, which you wouldn't normally have during surgery, which is an MR. And we've done some excitation conditions to kind of simulate surgery. And you're going to see this magenta surface kind of matching that surface to kind of give you a sense of how we're doing alignment. It's slowed down quite a bit, so so you can see it, but it's this idea of taking that preoperative data and then moving it into the operating room to allow it to align and then be representative of true structure. And so you see it's kind of slapping on. Again, the ground truth is the green. You wouldn't normally have that. But again, the idea is we don't put it in the surgery. Now the surgeon can use it for an accurate roadmap at current presentation. So this kind of framework looks like this, which if surgery is initiated, some form of surveillance system kind of working synergistically with the surgeon, perhaps some kind of AI-based process measurements, moving into automated strategies for alignment, all taking place extremely rapidly, and then having some form of augmented reality display, and then essentially improved guidance in this case. And this is kind of one of the hallmarks of our group, which is really to try to make these systems embedded in such a way that they actually kind of can provide additional information and additional guidance to the surgeon. One thing I hadn't mentioned is augmented reality aspect. So this is kind of right, you see a conventional display where I have a monitor nearby. I can be watching that kind of 4-panel display. But on the left, you're kind of seeing, what are we thinking about, which is kind of this idea of projecting that display more readily into the field so the surgeon can use it. And so we've been doing this in the lab. Now we're starting to get that same kind of capability. So it turns out this is kind of tough too in terms of how to handle it. But this is one option you might envision doing in kind of an augmented reality way. You might envision maybe a model view, right? You might have something where you have the actual 3D model geometry projected over it and used in some way. And so we kind of have been working on that within the lab as well. You can kind of see a mock-up of that right here. You can see a tumor kind of floating in space. This has been registered, and now we can kind of change our viewpoint. You might notice a little bit of a shifting there, which, that's part of working with technology to kind of figure out how to make it work well. So there's an aspect of the way HoloLens works that locks in for most kind of gaming applications, but for surgery, it probably needs to be a little more accurate. So we've been working on that to make it really accurate. And so what you see here in the top images here, we've actually figured out how to do some tracking with the stylus and be able to kind of create point clouds by using the HoloLens itself. And what you're going to see here is a vascular anatomy within a liver fan. This liver fan was actually built from a patient's set, and so the patient's anatomy there is actually shown there in terms of its vascular structure, as well as these models that you can see. And when as the student walks around, you'll be able to see kind of that reflect within the data, and things kind of go behind vasculature. So from a targeting aspect, we feel like we've kind of conquered some of that in terms of trying to use true AR to really do some targeting. So you kind of watch it right here, and you can kind of see as these tumors are they're actually going behind some vasculature. That you can see it kind of coming in front, and you can see it kind of really getting a good perspective. And so the idea of being able to perhaps target with an ablation unit or something like that, totally very possible in our mind. We're going to kind of continue to work on this and this blending of displays. And again, for us, we're thinking of it more in a collaborative way with robotics as far as kind of that sensing capability. So we've kind of conquered this first three areas right here, which is the registration and kind of moving into the patient. And so how do you do that to really help resection, right? So if we're talking about resection, we really want to make sure we clear the cancer margins as best we can. And so what's typically done is you do some kind of resection. You have kind of a mapping. The surgeon does a mental mapping to some degree. And they talk about superior borders and inferior borders and lateral and medial borders and the deep margin. And you typically will create some kind of pathology sample, and you'll send that off the path. And when we create that pathology sample in the operating room, oftentimes we ink it. Not everybody does it, but sometimes people use sutures instead. But we typically ink that surface, and it allows us to give a real good sense of what margin's what. So when they look at where tumor is on margin, where maybe perhaps an added resection needed to be, they can say, well, hey, it's probably on the margin in between the superior and posterior area, and that would hopefully guide them back into the tumor bed to allow them to do re-resection. But with all this digitization information going on, we should be able to do things like digitize that tumor bed and perhaps make a representation of that exact kind of mapping that they're doing in the OR, and then maybe perhaps put that back on the images and create essentially a virtual histopathology type record. And so that's something where we can look at our non-rigid registration in the context of that and see how we fare relative to the contrast enhanced lesion, perhaps have an estimate of what this is. Because the reality is that pathology resources are one of the most stretched resources in a hospital. So it's very difficult to do all that during case, although I'm going to show you a case of that in a second. But to do that during surgery is actually pretty challenging for the most part. So again, what do we know about, clearing margins and establishing margins in the operating room? It's pretty interesting. There's some papers out, very few, but a few that are out there that are kind of interesting. This is one from Kerala and Ong that looked at kind of how well can we find areas within a surgical tumor bed and be able to kind of re-resect areas where we've been told maybe some information. So this was an interesting experiment where they basically had a surgeon put in some sutures where the areas of pathology were going to line up with their specimen, and they placed those sutures in, and they kind of made some measurements associated with where the sutures are relative to other structures. And then the surgeon walked out of the room for 5 minutes, and they actually removed those sutures and then brought the surgeon back in to see if they could re-identify where those sutures were placed. And this is kind of the results of that study, which turned out to be on the peripheral as much as a centimeter, and on the deep margin as much as 12 millimeters on average. But you can see the range here is quite alarming. Okay, so when you think about even in the case of 5 minutes time, you still have quite a bit of discrepancy between what you visualize and kind of what you can do. So the idea of needing localization is definitely something to be needed. And then when you think about the idea of doing a re-resection, perhaps the patient goes home and they get called back when pathology comes back with results. That's an even harder situation. So I have a colleague of mine, Mike Top, over at otolaryngology, who's working on kind of creating these very detailed virtual 3D pathology reports. It's a really kind of interesting idea, and kind of bringing the pathology kind of into the operating room. This is work with Ji Wu here at Vanderbilt as well, and I'm kind of working with them on this as well. And so you get the idea of making these three-dimensional models that actually have all the detailed pathology, and as positive margins are allocated, you can kind of populate these margins and they become a really good record. And then if you can guide the surgeon or perhaps maybe use augmented reality, you might be able to kind of guide maybe the specimen back into the cavity in some sense if you're doing maybe intraoperative frozen sections, and be able to kind of take that margin information, the close margin information, and really get a good sense of where it is within the tumor bed itself. So that's kind of an interesting approach for this. I'm also working with them, and you might think of even in the case when they're not in the operating room, have to bring the patient back, or even in the operating room when there's a lot of distortion and soft tissue deformation. So we're working on that in my lab in conjunction with Mike. And so this is in the case of breast cancer, where we're using the Stereolabs camera to kind of capture the 3D pathology sample, and then this is primarily simulation. We're still working on this. But we've done some work dealing with distorting that tumor bed, shrinking it, pulling it, using retractors and whatnot, and then actually doing some simulation work where we take common effects that occur in pathology, such as a shrinking of the specimen and changing of shape. So this is kind of the situation you might be faced with, where you have a black point cloud that represents the tumor bed, and you've got a specimen that's much smaller in size as it's dehydrated and whatnot. And then can you figure out a way to map that using kind of some of the techniques, modeling techniques that we've done, and we're working on that. You kind of see some of our results here. It's coming along, and those that know some of the ARPA-H work that's going around, there was a whole call on this idea of making more precise surgical interventions dealing with really pathology specimens. So we're kind of working on that problem too, for that system. So, again, localization for improving, surgery is good. But what about therapeutics? How can we kind of work in that space a little bit? I'm going to speed up a little bit to make sure I kind of make time here. So we're working in the area of ablation, microwave ablation. And so this is really for any local regional therapy, and this is in cases of liver. And the idea behind that is you're bringing in this ablation probe. It's a imposing microwave level EM energy, and it's actually going to be basically agitating the water molecules to the degree that it actually causes ablation to happen, a thermal cooking of the tissue more or less. And typically, if you have a centimeter tumor, a tumor that's a centimeter less and pretty much accessible, they can do this quite effectively. And there are guidance systems that are out there, but recurrence is quite common, and it has a limited number of indications. And one of the things that we want to work on is, rather than being brought to systemic therapy, where therapeutics are becoming much more, much better than they were. And so the idea of patients moving from palliative to perhaps ablative scenarios is something we're really interested in, as well as making more conformal ablations, being able to ablate things that are kind of would not normally make it into the indications. We're trying to kind of expand that process. So we're really working on a lot of localization work and advanced registration. So we're pretty good at modeling. And so what you're seeing over here, this little red dot up here, is basically our best modeling guess when we simulate microwave ablation. If we know enough about the properties of the tissue, we can do a pretty good job of estimating that. And what we wanted to look at is, we're doing all this registration and alignment work to guide these things. What happens to our positive predictive value, in terms of our overlap with what we want to do versus what we actually do when we're in the presence of misregistration. So what you're seeing here on the x-axis is target registration error, and then we see the positive predictive value, the overlap essentially kind of our planned ablation versus what we actually do. And so as you can see, as my methods get more accurate, I obviously get better predictive value. But as you look at it, you can see it's quite clear that for every basically millimeter of error, I lose about 6% of my volume. So if you're 3 or 4 or 5 millimeters off, and we're in those ranges with these soft tissue deformations, you're losing 20 and 30% of your predictive value just in that process. And then I made the assumption that I could predict things. So from the modeling side of things, what if I use the wrong properties or use the wrong things? I could actually lose quite a bit more. And so we have this kind of challenge. This is kind of going into some of our digital twin work. So one of the things, why do we care about properties and things like that? So we're trying to look at imaging data and what can it do for us in terms of being predictive. And so it turns out fatty liver disease is one of these common things that present with cancers. And so can we use fatty liver disease, which, that affects thermal things, right? Probably fat does. And so can we use these things to kind of figure out ways of making the models more accurate, more predictive, and then move on and be able to correct for deformations to make these things much more accurate. So this is the kind of typical stuff you get in a Medtronic type type system with an app or something like that. And so we're working on ways of taking imaging data, things like fat quantification and anatomical imaging data, making more accurate models, things that are dielectric and thermal properties that are dependent on it, that we're doing some measurements that look at kind of how thermal conductivity changes with fat content. So can we take the fat content from a patient and then just deposit the appropriate dielectric properties in order to kind of create these very accurate modeling methods? And then can we use all the deformation correction stuff that we've done in order to kind of make the guidance system more accurate? So this is kind of I was talking about the components that have changed. This is the idea of bringing simulation predictive aspects into the theater where you can't do all the measurements. There are measurements you can make, but not things that deal with all these comprehensive things. So can we bring those kind of high-end computations to the OR? And just to give you some example really quickly, this is ablation volume delivered. This is thermal dose, and this is basically the fan base based on low fat to high fat. So you see quite a bit of variability in terms of ablation volumes when you have varying content. So the idea of this seems to be a pretty decent one for trying to kind of bring more sophisticated computation there. My time really quick. I'm gonna skip through this last one pretty quickly, but the last thing I wanted to talk about was, okay, that's great. We have all these technologies that help us do surgery, but how do we use them to guide surgical training? Okay, and this is kind of getting a little bit into the robotics. I've worked with Nabil Saman. And so we're very familiar with the paradigm of see one, do one, teach one. That's the common way that we train in surgeons. It assumes that we have essentially a cadre of surgeons available to us that can provide that training. Protocols have been developed to do this. Societies have adopted it. It's subjective assessment has been shown to be very effective. But when you think about developing countries, those cadres don't really exist as much. Oftentimes there's a drain of these folks where maybe they're coming from constrained countries. They go to places to get trained, but then they often don't return. And so there's an issue. How do you train folks when the cadre is there not to do so? And so that's one of the things we're working on to meet that need, and we're doing this with the Wellcome Trust as a grant associated with them. This is the team that's working on. Again, this is led by Dr. Nabil Saman here at Vanderbilt. And the general idea is to create an exoskeleton that allows us to kind of do a whole new version of haptics. So can we allow surgeons to train realistically to do things like cholecystectomies, which this one is geared at, and allow the robotic exoskeleton to kind of act as appropriate haptics. And you kind of see some of the robotic systems here happening where Dr. Idris is able to move this laparoscopic manipulator as much as he needs to, and then basically the system itself can actually either monitor it for training purposes and evaluation, or it can provide the appropriate haptics and control, like you're seeing here, in order to kind of achieve that. We're also tying, so rather than, well, that's great. You have the ability to do the haptics. Well, you need the actual procedure to do. And so we're working on ways of being, this is actually fairly old. We're actually much more sophisticated than this now, but the idea of actually having a simulator with a HoloLens coupled to the exoskeleton is kind of where we're going, which is kind of really interesting conception of a simulator. But again, you could have all the training aspects associated with this all self-contained within a low-cost system in order to kind of train folks in areas to do these types of procedures. We're doing aberrant anatomy and making models that are very sophisticated with respect to what they do in terms of using FEM. We're starting to work on ways of doing the different manipulations and blunt dissections, as well as cautery, as well as general other aspects associated with clipping and clamping. And then we're also doing, that's great. We can do all those models. Anybody who knows XFEM or FEM, they're kind of slow compared to doing, faster than video frame rate updates. And so we're actually using machine learning and physics informed machine learning in order to achieve this. And we're getting down to millisecond level of interaction. So it's really getting to that This is done with Sohail Khoury. It's also part of the team. So it's really great. So hopefully that gives you a little bit of an idea of a lot of different areas to some degree where essentially all this kind of more sophisticated area of guidance is coming in, and where modeling can play a role as well. And so with that, I'll take questions, but hopefully you found it worth your time. You've gained some insight from my expertise, and maybe saw some opportunities in this research environment. So I have some time for questions. I'm more than happy to take some.
Professor Miga, that was a very fascinating, insightful talk. Thank you. We have got a few questions that have come in from the audience here. So here's one. Are there any robotic systems out there that deliver microwave ablation?
There are many, commercial vendors that do microwave ablation. Yes, there's many. New Wave has a system. Prescient, Medtronic's Covidian system is also. So there's several systems that do microwave ablation. Yes. As far as the guidance systems and things like that, there are some that are coming online. I won't comment on any of them. Oftentimes they are not as efficient as they need to be. Oftentimes they are done in the context of IR. The casination system is one of those as well. But ablation is one of those, things that can be done in a lot of different contexts, including open surgery, laparoscopic, and percutaneous. And so there's real need for dynamic conditions of delivering those kinds of therapies, and oftentimes the indications for use are quite limited. And so one of the things I didn't kind of highlighted in there is we're thinking of microwave therapy in a more conformal way. So there are some sector arrays that deliver microwave energy kind of sectorially, which is kind of interesting, right? And then there are also this idea of if you understand how to predict it well enough, can you really make headway in terms of expanding the indications, the size of tumors, and the control and the approaches that you use? That to me is a really interesting question for the future. And again, going back to, you're seeing a lot of advances in therapeutics in such a way that they're making this more possible. Tumors are shrinking. People are moving from palliative to being surgical candidates or ablation candidates. So it's kind of super exciting in that way. And it actually kind of emphasizes, one of the things I think that's really challenging, even in robotics, is, you develop these systems kind of thinking that the clinical condition is going to be like that forever. In my career, when I first started, I was working really in the neurosurgical area and expanded into liver. But back then, primary liver cancer was smaller than, in terms of its patient population than it was for brain. And then over the years, due to things like fatty liver disease and various comorbidities, there's been a change in such that there's been quite a bit of growth in cancer associated with liver over the years. And that's directly related to changes in etiology and things like that. So it's kind of interesting.
We do have a few other questions actually coming in. So I know your models utilize thermal coefficients, dielectric properties. So are you working with MR thermography at all?
MR thermography is great. I think it's a good validation tool. You can certainly use it to assist, and there certainly are systems that are out there that are using it in a way to predict that. But it is an MR thermography system, so the infrastructure and the encumbrance around that do have to be taken into account. It certainly is a very viable technology to assist with understanding ablative context. But you remember, thermal energy, when it gets deposited, boiling water doesn't cool very quickly, so you're really trying to control, right? So you really have to have more of a predictive aspect to it, even with thermography, because once you deposit that energy, you can't take it back. And so you really do need to have even good predictors associated with that if you wanted to use it, even in the MR thermography scenario, if you can get by some of the workflow aspects.
So have you been looking at MR-EPT then to actually derive the physical dielectric conductivity properties from the patient?
Well, that's one of the things we're looking at, is looking at fat quantification imaging for that very perspective. But there are electroconductivity imaging type things you can use. I think it matters as to, are they a good surrogate, and have you validated against good ablative experiments. But I think that emphasizes the idea of digital twins, though, which is pretty exciting, to kind of bring in as much data as you can that's been validated and verified in order to kind of make these predictions better.
And there's a good one last one. I think it's more broad. Is what are the main barriers to entry with surgeons using AR in their day-to-day activities?
It's a great question. It's still unknown. I think what I'm pretty, I've seen, this is the third time I've seen AR in my career. Actually, some of the very first work was done at Dartmouth, where I did my PhD. And it's always been not sophisticated enough. The sensoring aspects have been not kind of far enough along to really make it effective. I'm kind of a believer right now, in the sense I think the HoloLens is a sophisticated sensor package that can do quite well. So I'm pretty impressed with it. I think there's still weight requirements that are still a little off. The HoloLens is better than some of the other ones, a little lighter than most. So there are some aspects of that. I still think there's an aspect that surgeons don't like their field really, really super cluttered to some degree. So there's an aspect of how it interacts with the surgeon that's important. But I do think the sophistication is getting there, and it's actually worth really looking at as a technology. I do think the lack of having to look away from the field to get guidance versus in your field and getting that information that's necessary, I think is it's there. The displays are quite remarkable. So I do think one of the biggest barriers, biggest probably head weight is a little bit of disorientation.